If I'm muting one is coming back. People are just, yeah. Palash?
Yeah.
I think we have reached 90. So Palash, I'm making it is live on Facebook because after 100
sure,
maybe people will not able to join.
Yeah, yes, right. Okay, so Shudipto, since you want to take up one question, so the first question that is there, SpO2 target for mild, moderate, and severe disease.
I think the target saturation, it is not dependent on.
A little louder.
Hello. Am I audible?
Yes.
The target saturation doesn't depend on the mild, moderate, or severity of the disease. It basically depends on the patient's clinical condition. And as we understand from the pathophysiology, a saturation more than 90 is sufficient to maintain perfusion unless there is some active myocardial ischemia is going on, or there is patient is severely anemic in that scenario. Otherwise, saturation more than 90 is sufficient. Even in a COPD patient, we can tolerate go a little lower, maybe 88 saturation is fine.
Okay.
But whether
so I think Paramita is back online.
Yeah. So we come back to this point where there is a flow chart given by the AIMS where we have this oxygen therapy at home, right? So we have this, if you have a fluctuating oxygen saturation, then you have to titrate this oxygen. Okay. Now, as well as you have to keep in mind the respiratory rate. Even if you have a 93 or 94 saturation, but your respiratory rate is high, then you need to be actually admitted to a hospital. You cannot stay at home with an oxygen nasal cannula and have a respiratory rate of 44. No, that is not allowed. So you actually have to see whether with the oxygen therapy you are stabilizing. Say, suppose the numerics is not so important as Dr. Shudipto was saying. Say 93, 94 is fine. In a COPD, probably you would accept 90. But that is not the point. The point is whether the patient is stable with it. So you would not have the options of having a ABG at home, right? You can't draw an ABG at home and see. But you can definitely see the respiratory rate is high or low. So in that case, the desaturating, trailing the saturation, these patients should not be there at home. But if you do stabilize at a certain point of 93 or 94, then you can maintain at home and go on with the other medications, etc. But once a patient is desaturating, these patients would actually have a COVID pneumonia, which is not mild. A mild. Right. So these are some of the indications where we would also see not only the oxygen.
Paramita, please unmute.
Paramita, unmute.
Hello.
Yeah. Now audible.
Achha. Okay. So till now you couldn't hear anything, right?
No. We heard just last one.
Last. Okay. So that is what I wanted to impress, that the things like respiratory rate, because nowadays telemedicine is the talk of the day. And so not only the oxygen saturation numerics is important, it is also important that you see that with the oxygen therapy, the patient stabilizes. If supposing there is an amount of desaturation and you're going on increasing demand of oxygen, then you should be actually hospitalized. But if you stabilize with this amount of oxygen, then it is fine. But for a mild disease, to have a oxygen requirement will be very rare. Okay. And there may be other people like patients with COPD or interstitial lung disease, etc. These patients would any which way have a basal oxygen saturation of say 90 or 88. So those patients, the target is not 94, but for a normal healthy adult, the target would be 93, 94. Okay, so respiratory rate, other stabilizing factors, like if you have a hypotension, then you have to admit this patient. But otherwise, with this overwhelming state where we did not have beds in this city, then we have treated patients at home with oxygen cylinders, with steroids, etc. And they have stabilized over the days, and fortunately are still hale and hearty. So to go on from here, I would say, so that the next slide. Okay, now home oxygen therapy would, the clinical parameters, you could use a portable pulse oximeter, and another thing, you would have to see what is the heart rate. If the heart rate is below 45 or above 120, then you also would think that this is a rate limiting affair, where bradycardia or tachycardia can be a manifestation of anxiety, exaggerating the heart rate, or the bradycardia is actually not a very good thing to do, because we have all seen that myocarditis is something which is not rare in COVID. We have seen viral myocarditis, which is transient and which is present in these patients. And if you have an oxygen demand with a bradycardia, it would rather be advisable to admit this patient. Rest of the, fever is not that important. The fever would go in a certain days with certain time, but fever would not be actually a parameter where you would rush into a hospital. But definitely your respiratory rate going above 30 or say 33 on that cases, then you would definitely tell your patient to go and get admitted. So you actually have this parameter where you increase this oxygen in 1 liter in allocates and see whether it comes down to a point where you could reassess this patient and stabilize him in 24 hours or till the time he gets bed. Or these patients who have healed by fibrosis going home would be on long-term oxygen therapy. So now there is a breathlessness screening tool. Now this is a useful tool where the maximum number of numbers on a single breath. So suppose we tell you ki ek nishashe apni kotota 1 2 3 4 gunun kotota gunte parben. So if this is less than 7, then there is cause for concern. Or the time between consecutive breaths, একটা নিঃশ্বাস নিয়ে আরেকটা নিঃশ্বাসের মধ্যে যদি less than 5 seconds থাকে, then that corresponds to actually a saturation of less than 90 in room air. So this test actually has a sensitivity of 87 to 82%. So that means you can use this test as one of the clinical tests where you don't have, in the remote corners. Now we are facing that beyond the cities, the villages are actually being affected with COVID-19. There the facility of oxygen, there the facility of having a pulse oximeter in the evening time. So suppose you won't get a pulse oximeter, say in a village in Medipur or say Durgapur, right? So what do? That patient you have to treat. In that case, you can use this or a 6-minute walk test. So these are the few correlations which would help you for home oxygen therapy. Now the maximum number of counting, when you count the number, the maximum number of counted numbers on a single breath, if less than 10, or the time between 2 consecutive breaths is less than 7, then that corresponds to a saturation of 95. So in that case, you are safe. But if it is the maximum number that you're counting is less than 7, then that is a cause for concern, and you should actually try and get these patients to the hospital. But again, our hospitals are all overloaded, and even if they come to a hospital, I do not know how far we are being able to get oxygen to all of these patients, right? So instead of saying a patient, go away, my hospital doesn't have a bed to give to you an oxygen bed, it is better we start this therapy at home and then try for a hospital bed for the interim time. That will save the patient's life. And next slide. We have different devices like the nasal cannula, where we can go from 2 to 4 liters, and there are other therapies like we were talking about oxygen concentrators, right? So oxygen concentrators today is portable, it is cost effective, easy to operate, useful for home actually, and it helps in emergency because cylinders you need to refill, which may be a problem. Again, the basic problem which happens here is patients who are on home oxygen therapy may be a moderate form of the disease, because mild form of the disease rarely would need oxygen, but these moderate form of the disease, they actually, you can take your oxygen concentrator, which is portable, and you can take it to the toilet. So or you can have a bath. So that form is a huge additional benefit, because patients in intensive care nowadays are there for 22 days, 1 month, and they cannot bathe. And that becomes a huge problem for the patient. We may not feel it medically, but for the patient who's there, many of our doctors have been there. We know what pain they go through. So these are some of the comfort levels you have when you have an oxygen concentrator. Oxygen concentrators, the main problematic part is you do not know whether you are giving 100% oxygen. You may give 4 liters of oxygen, but it may not be the 100% oxygen that you are giving. So that part you have to clarify. And otherwise, you can go in for the oxygen cylinders. Usually the cylinders which are given at home are the B type. Now, this is a standard B type cylinders, which would be 14 kilos in weight. And this would last for about 10 to 12 hours. And again, the methods of oxygen therapy delivery, if you have the long-term oxygen therapy in oxygen for patients with chronic hypoxemia, these cylinders would last, one cylinder a day, 15 hours. Ambulatory oxygen therapy is during exercise. So patients who are not hypoxemic at rest, but who would need oxygen when they're walking, etc. These are the patients who need ambulatory oxygen therapy. Some patients do need nocturnal oxygen therapy, like those patients with obesity. They need that CPAP, etc. Short burst of oxygen in which a brief and intermittent oxygen supplementation are used, needed in the absence of hypoxia. A patient in hypoxia cannot have a short burst of oxygen therapy. It has to be a continuous oxygen therapy. So nowadays, oxygen cans are very much in vogue, but a can only give you an oxygen burst therapy. So that actually is not a good way of dealing with things. Palliative oxygen therapy is for relieving the breathlessness in advanced life-limiting diseases like interstitial lung disease, etc. So, like if this patient, say, suppose has a COPD. Okay. Now, if a resting PO2, your resting PO2 is 55, then you have to think about giving oxygen. And if around 88, COPD with 88 saturation is a normal saturation, you have to accept that. Or a patient who is in port pulmonale or a right heart failure, etc. These would be the patients, they need long-term oxygen therapy. In the times of COVID-19, we have extrapolated this, and we are using the same therapy we have, like, remdesivir was actually being devised for Ebola, and we have extrapolated this to COVID-19, right? So similarly, actually these ambulatory therapy oxygen or these concentrators were for the COPD cases or for the interstitial lung disease, which needed a long-term oxygen therapy. So we have extrapolated from there to a common lifespan where oxygen was needed, and we could not have, our health system could not have provided them with the healthcare facility that was to be given. But the peak of pandemic, we saw everything. I mean, in our societies, actually, we bought 5 cylinders, we bought 5 concentrators, and we were distributing them in the high rises so as to say that at least till you get a bed, you can have oxygen. So in that way, a lot of lives were actually saved. So what happens, say a patient has any which way, that patient has a COPD. Okay. Now for that patient, I wouldn't target 94 definitely. That would be the basal oxygen level that patient any which way would be having. Other patients, like we have seen a few of these interstitial lung disease walking into intensive care, they usually have this oxygen at home. So that again, these patients where there is pulmonary hypertension, cystic fibrosis, or advanced cardiac failure, they have a long-term therapy, oxygen therapy, and we don't mind taking them in. And the low flow oxygen cannula, you can go up to 6 liters. And with the simple oxygen mask, you can go from 6 to 10 liters. And the oxygen here would be 35 to 50%. But that would depend on the patient's respiratory rate as well and the mask fit. And the room air enters through the sides of the mask, so you cannot give 100% oxygen through the simple oxygen mask. You can use the venturi mask, which is also called as the entrainment mask, which utilizes a flow meter, to devise a certain amount and oxygen delivery. So there you can go from 24 to 40%, right? So oxygen comes from cylinders. A home oxygen concentrator can give you a long tubing, so you can get an ambulatory patient, which is very important. We have a lot of thrombosis complications in these patients of COVID-19, and in the intensive care, you would never get an ambulatory patient. But at home, you have this, advantage where you have a long cannula and patient can be ambulatory. So that part is an additional benefit in these cases. A portable oxygen concentrator is a smaller one, which is lightweight and is designed that when you are traveling, you can carry it. So portable oxygen cylinders are a bit costly. They give you from 2 to 4 liters of oxygen, but that again is very handy, right? So what are the complications of oxygen therapy? That part we never deal with, because we all talk of oxygen is a drug and oxygen should be prescribed. It should be written down how many liters of oxygen you are giving and whether you are increasing or decreasing. And in a hospital setting, actually, you have to titrate the oxygen. But we never talk of oxygen complications from oxygen therapy. We never say that there are potential toxicities of patients being administered high concentration of oxygen above 50%. Like the atelectasis is one of the major complications which we do face, because I have seen patients who actually think that oxygen is a very good thing. They do not think oxygen is a drug, and they increase the oxygen by themselves. My patients in my intensive care, they turn around, they know how the flow meter goes up, and every night they keep going up on the flow meter. I come back in the evening, say suppose this patient was on 4 to 6 liters of oxygen. The next morning I go back to see that the patient is in 12 liters of oxygen. When I question my sister, she says, madam, ami ki korbo, patient to nije nijei bariye nai. So I think we also should send out a message to the community at large that oxygen can also damage you. It can cause oxidative stress, atelectasis, peripheral vasoconstriction, and uncontrolled oxygen delivery can lead to a worsening of hypercapnia, in the COPD patients. So we should be very careful in giving oxygen to COPD patients where having COVID-19. It's like a double-edged sword. You don't give oxygen, you have problem. You give oxygen, you have problem. So in a COPD patient, we need to be very careful, especially in home care therapy, because that should, if that patient is under telemedicine, you have to frequently visit that patient on telemedicine and actually titrate the oxygen, that it does not lead to hypercapnia. Because at home, we don't have an ABG to see that. You have a pulse oximeter to see oxygenation, but you wouldn't have a capnograph to see the carbon dioxide, right? So that part we have to actually keep in mind. However, the benefit always outweigh the risk. it is advised to keep the saturation to 90 to 92. Okay. The ideal figure is 94, but 90 to 92 is something which is acceptable to prevent tissue hypoxia while minimizing any side effects which might be associated with excessive oxygen supplementation. Patients should be made aware of dangers of using oxygen at home in presence of any naked flame such as cookers or candles, because this is actually oxygen can be a fire hazard. So there is a significant risk of fire associated with people who smoke. So smokers using ambulatory oxygen therapy at home, especially cylinders or say concentrators, smoking cessation should be advocated. Any patient, even if he is not the patient, his parents are the patient and he is a smoker, should be advocated. Please do not smoke at home, because fire hazard due to oxygen therapy at home is actually a reality which we should tell the people at large. And a written education should be given to the patients before ordering home oxygen therapy. So oxygen cylinders actually should be at least 5 feet away from any naked flame or a heat source or electrical devices. Thank you.
Well, that was quite comprehensive. We also talked about some of the factors that are not usually talked about, like the situations where you need chronic oxygen therapy, and home oxygen therapy is an useful one, and also the problems of excess toxicity. I would like to come back at the very end, how to minimize oxygen usage and wastage. So I think your input would be required at that point of time. But right now we would move to the next stage. So a patient who has got admitted into the hospital ward, and how to manage the oxygen as a drug therapy. To speak on the topic, we have Dr. Susmita Rai Chaudhuri, who has been actively treating COVID patients since the scourge hit us. And though her hospital has changed, but the number of patients that she has to manage is phenomenal. So Dr. Susmita Rai Chaudhuri, I welcome you on this our forum. She is a pulmonologist and an interventional pulmonologist, and currently heads the ICU at Fortis Hospital. She will talk about the oxygen therapy in the ward. Over to you, Dr.
Thank you very much for having me. Thank you. Thank you very much for having me. I'm a pulmonologist, as we said, and one second, I will try and get this. Is it visible?
Yes, we just need to make it full screen.
Can you see? Okay.
Yeah, it's fine. Perfect.
So yes, I'm a pulmonologist. Obviously, all of you who are anesthetists, I don't think I really need to say much, but I think it's just recapitulating and doing what is best medical evidence-based practice. Paramita Di has said a lot of things, and I think we will be overlapping quite a lot. And I will skip on the things that she has already spoken about. So just the basics, we know that no oxygen, no life. So it is basically an elixir of life, and lots of poets have written lots about oxygen and no oxygen. So it is a drug. What we always have to remember, and we keep forgetting, is that oxygen is a drug and it must be prescribed. Just telling a nursing staff that start oxygen on this patient is not good enough. In the medical legal world, oxygen is a drug and must be prescribed, and we'll discuss that a little bit more. On an average, oxygen delivery basically depends upon a good ventilation, gas exchange, and effective circulation. If these are absent, no matter what you do, it is not going to be useful. We already know from our medical school days that there are two types of respiratory failure. Type 1 is hypoxic respiratory failure, and type 2 is hypercapnic respiratory failure. So, but in both, the oxygen levels are low. So when I teach my medical students, I always ask them a question: what is going to kill you or hypercapnia? We are always worried about COPD patients when the ambulance drivers brings them from home in an acute exacerbation in respiratory failure, giving them 10 liters of oxygen and their carbon dioxides being 75, 80. So I'm still not worried, because as long as their oxygenation has been maintained, we can do something about the carbon dioxide. But if the patient is hypoxic, he might not even reach the hospital. So hypoxia kills always, and hypoxia needs to be treated. Hypoxia needs to be well treated. And that is what COVID-19 has taught us completely. So what are our clinical goals when we are giving oxygen therapy in the ward? Is to A, improve oxygenation, B, decrease the work of breathing, and third is decrease myocardial work. So we are being quite intelligent here. We want our heart to work well, and we want our tissues to work well. And that is why we need to improve oxygenation. When we talk about oxygenation improvement, how much are we talking about? Paramita has already alluded to the fact that we don't really need everybody to have oxygen saturations of 99 to 100%. The goals of oxygenation are not very clear, but definitely anybody who has type 1 hypoxemic respiratory failure will need oxygenation. And the experience has taught us that the saturations of 92 to 95% maintains tissue oxygenation adequately. Having said that, there is some evidence behind it. This paper in New Journal of Medicine in 2020, where liberal or conservative oxygen therapy for ARDS syndrome was seen, they showed that the potential harm of maintaining an SpO2 of less than 92%, it assigned ARDS patients without COVID-19 to either a conservative oxygen strategy, which is 88 to 92, or a liberal oxygen strategy, where SpO2 kept above 96%. It had to be stopped early due to futility after enrolling 205 patients. But what they found was the conservative oxygen group, there was increased mortality at 90 days in those who had lesser than 92% of saturation. So therefore 92 is not just an arbitrary mark. There is some evidence that below that, tissue oxygenation and 90-day mortality, especially with COVID-19, can worsen. And why do we not want more than 96%? Obviously to the fact that we are all dealing with oxygen supply issues, so many people in the pandemic needing oxygen. And in addition to that, this study, which also showed a systemic review and meta-analysis in Lancet in 2018, that above SpO2 of 96%, 25 randomized controlled trials found in patients without COVID-19, this is not even with COVID-19, that a liberal oxygen strategy was associated with an increased risk of in-hospital mortality compared to a lower SpO2 comparator. So 92 to 96 quite nicely takes on tissue oxygenation. Therefore, too much and too little of everything is bad, and we take it from there. Now, when we talk about what are the delivery modes when our patients require oxygen in the ward level, there are two types of delivery methods. One is the low flow variable performance, where there's a stable ventilatory pattern to the patient, where you don't need to give any help in ventilation, but just in oxygenation. And it also depends upon the ventilatory demands of the patient. So it is a variable performance method, and we'll talk about it. High flow fixed performance methods, where an inspired gas at a preset FiO2 is delivered continuously at high flow, and it is independent of a patient's breathing pattern. So low flow variable performance, what do we have devices there? We have the nasal cannula, we have the nasal catheter, the nasal mask. Nasal mask is usually something used with a CPAP machine in stable patients with obstructive sleep apnea who are not mouth breathers. And because this is not usually used in the ward areas in COVID-19, I won't be discussing it. So the common ones that are used are in low flow devices are nasal cannula, simple face mask, the reservoir mask, which can be a partial rebreathing mask and a non-rebreathing mask. And the other ones are the high flow fixed performance devices, which are bag masks, which all of you know way better than I do. Breathing circuits, venturi mask setting, and we'll discuss this in a bit. So in the armamentarium that we have is the cannula, the face mask, The rebreathing, starting oxygen, as we said, it is a drug. It meets out, it has to be documented. Method of delivery, oxygen concentration and rate, and in light of mucormycosis and mucor-like and other fungal infections happening, definitely a written advice to the nursing staff for oronasal care of the patients. Also ensure that the area from which the humidified oxygen is coming, that the water is changed every day. Ensure that the walls do not contain molds, because I suspect, rather than the zinc theories and the ferritin theories and the steroid theories, it is what kind of oxygen. We have never, it's an unprecedented times where we are delivering a lot of oxygen for a very long period of time. So ensure that the high flow oxygens that are going do not carry the molds with them. So the walls, the oxygen reservoir, the humidifier, and the system through which it is going is clean. So to write, please give such and such 2 liters nasal cannula and continue to titrate up and down to keep saturations of 92 to 96%, and nursing staff advised to take care of oronasal care. This much is very important, I think, in the days to come if we look at cases medico-legally. Let's recapitulate nasal cannula a little bit. It delivers 1 to 4 liters per minute. Some people say up to 5 liters, which corresponds to a maximum FiO2 delivery of 24 to 35%. And flow increases approximately through this device by 1 to 2% with every increase in oxygen flow per liter. The advantages of a cannula, I don't need to reiterate. It is comfortable. You can have humidity control. Again, in light of mucor and other infections happening, when the oxygen requirement is 2 to 3 liters per minute for low flow, you do not always need to humidify. The reason you need to humidify oxygen at higher flows is because it irritates the nasal mucosa. So at lower flows, you can always give oxygen without humidification. Those who are pulmonologists will know that we do prescribe patients oxygen at home in interstitial lung disease or COPD, and those requiring 1 to 2 liters per minute do not always need humidification at home. The disadvantages, however, of prolonged nasal cannula usage is there can be pressure sores. More than 5 liters is quite poorly tolerated and leads to crusting of nasal mucosa. Coming to simple face mask, these are disposable plastic devices which cover both nose and the mouth, and the minimum oxygen flow required through a face mask to give you an FiO2 of 0.3 is 5 liters per minute, and that avoids rebreathing and excessive respiratory work. So somebody needing 2 liters per minute, but you give them a face mask, is not going to work at all. Instead, it is going to increase their respiratory work further. It can give a maximum oxygen flow up to 10 liters per minute and an FiO2 of 0.6. And all of us have seen something like this on our day-to-day workloads in the hospital. Coming to reservoir masks, I find that this is one device which most of us don't really understand. We just put it on the patient and don't know what we are doing with. So simple, reservoir mask is nothing but a simple face mask which has a gas reservoir, in which it can either be a partial rebreathing mask or a non-rebreathing mask. And what is the difference? A partial rebreathing mask is a simple mask with a reservoir bag. And here there are no valves. There is just a bag which is attached to a face mask, and through the patient's expired tidal volume, part of the patient's expired tidal volume refills the bag. So the patient inhales 1/3 of his expired air and 2/3 of the fresh air. The two together form a combination. So those who are requiring 6 to 10 liters per minute, it can provide up to 40 to 70% of oxygen. And where it can give more than what a simple face mask can. And their partial rebreathing mask, there's a reservoir, the inspired oxygen, and then an exhalation port. How is it different from a non-rebreathing mask? It is different by, in a non-rebreathing mask, there is a valve. So first fill in the reservoir bag with oxygen. And then there's a mask, there is a little valve which avoids the expired air to come back into the reservoir bag. So you're getting full oxygen that is coming into the reservoir bag. Again, in the exhalation port, there is another valve so that none of the expired air comes back into your mask. However, there's a caveat to it. If this is not well fitted onto the patient's face, you can still rebreathe your own exhaled air. So it's not foolproof. The non-rebreathing masks are partial rebreathing masks with flap valves between the bag and mask and the exhalation ports. The good thing is you can give up to 100% of oxygen. It is way more comfortable for a patient to use rather than a non-NIV, non-invasive mask fitted onto their face. So minimum flow required is 10 to 15 liters per minute. But the caveat is a good facial seal and proper flow rates are necessary to avoid rebreathing carbon dioxide in these patients. And this is how it is. So 1 to 4 liters, they say 5, but I would say 4 liters, 0.24 to 0.35 is the FiO2 estimate in a nasal cannula. In a face mask, 6 liters, estimated 0.4 to 0.6. And in a non-rebreathing mask, it can be 10 to 15 or 10 to 15 liters and up to 100% of FiO2 with a reservoir bag. So that is what makes it simple and how much we need to deliver for these patients. Coming to Venturi mask, these are things that are very least used and should be used, especially in patients who are coming out of intensive care unit, those who are coming out of high dependency units, where you want to give a high flow, fixed delivery air entrainment system. So it is basically based on Bernoulli's principle, where velocity of fluid increases, the pressure decreases. So the goal of a Venturi mask is to create an open system with a high flow around the nose and mouth with a fixed FiO2. So as the velocity is low and pressure is high, it comes through a constricted area where the air gets entrained, and here it mixes with 100% oxygen and gives exactly fixed amount of oxygen that is required by the presence of the little constriction there, which is in most cases color coded and helps decide on a day-to-day basis. So this area which is constricted, if it is blue, it delivers only 24%. So whether you make the oxygen flow 10 liters or 11 liters, it will only deliver 2 liters per minute. So if you want somebody to have a 28% FiO2 and a fixed 28% FiO2, you change this connection to a white one, and that delivers 4 liters per minute. The orange connection will deliver oxygen to 31%, which is 6 liters per minute. The yellow one gives you 35%, which is 8 liters per minute. The red one delivers 40%. This way, A, you are giving precise oxygen. B, you know if your patient's oxygen requirement is coming down. C, you do not waste oxygen, which is quite important in the COVID pandemic right now. Here in our units, actually our patients will compare with each other, which color are you on? Am I getting better? Some of them. But here, the important thing is that your nurses know which one they are using. Sometimes they'll put a red one and put 4 liters oxygen. It doesn't work. So they have to know which color is equal to how much. The good thing is that these detachable color coded devices have it written on them, 35%, 8 liters, or like that. So it is easier for the nurses to use. And this is something I think we should be using more. We haven't been using it as much as it should be used in our COVID pandemic, while the patient is getting better with hypoxic respiratory failure. Nothing gets over without discussing awake proning and oxygen about it than we ever did with ARDS. And always we knew that proning was a method of COVID has taught us that it is an adjunctive therapy which is normally used in ARDS but can be used in awake patients as well, irrespective of how much oxygen they are on. So what does it do? We've learned that supine position leads to atelectasis, and proning can actually help open up atelectatic lung. So whether the patient is on a nasal cannula with a face mask or non-rebreathing mask or a Venturi, along with that, if you prone it by matching the ventilation and perfusion in the areas that are atelectative, especially the basal. Also, it helps improve secretion clearance. It can be used on any level of respiratory support, even in the ward. The longer you are prone, the better it works. So when people are prone the other way, it is 12 to 18 hours ideally, but in awake proning, we advise for half an hour every 2 hours if somebody can prone it, or for as much as longer as they can, it helps. But it requires a patient that is cooperative with intact mentation, and that is where the drawback to it is. Complications have already been discussed. Oxygen toxicity, which may lead to lung injury, which can add to the lung injury already that is happening due to COVID. In COPD patients, hypoventilation and hypercarbia can result if you give too much oxygen. So controlled FiO2 delivery of 24 to 30% is the norm. We do not want very high saturations. 88 to 92% is what we target. Absorption atelectasis can happen within 6 minutes of 100% FiO2 inhalation. So therefore that needs to be avoided. Obviously, free radical injury is another chapter altogether. Also, we must not forget that sudden correction of hypoxia in somebody who has been hypoxic for quite a while can abolish the sympathetic acting to hypotension and circulatory collapse. These are things to keep in mind when we are looking at these patients. And I will conclude my patients of oxygen therapy in the ward by saying that COVID-19 infections patients presenting with SARI, oxygenation is one of the modes of therapy, and it has to be adequate. It is a drug. We need to prescribe it appropriately. The target saturations in all patients, irrespective of mild, moderate, or severe, is 92 to 95, unless they have COPD. Tight use, and there are various delivery methods available in the ward setting to be used as appropriate. Thank you very much.
Thank you, Dr. Roy Chaudhary. That was very succinctly delivered message. What device to use, when to use, how much oxygen to deliver, how to monitor, and how to look out for, and especially the points about mucormycosis is very well appreciated, because this is something that we obviously read about our textbooks and then forgot. And it's coming back to us in a very, very major way. And probably with the India being the diabetes capital of the world, and various therapies, and maybe COVID-19 also itself contributing to a completely, the arrangement of glycemic control, all these things must be kept in mind. And especially as you have mentioned this thing about medical legal aspects about patient getting mucormycosis and probable blame coming to non-sterile settings contributing to it must be kept in mind. Thank you. We'll come back to the questions. So next we move to Dr. Sudipto Mukherjee, who is a consultant critical care specialist at Tata Medical Center. And though his background is anesthetist, now he practices critical care exclusively. And now we will move to oxygen therapy in the ICU. We will not discuss a few of the advanced modalities like ventilation and invasive ventilation and ECMO, which are rarely used, and the outcome is often very, not good, but whatever. The other two modalities in the ICU, which has changed rapidly as our knowledge has advanced, and these are the most important methods employed in the ICU now compared to the first few months. Invasively, we have moved away from that. And what is latest in those things? Dr. Sudipto Mukherjee, please.
Hello, good evening, everybody. Thank you, Dr. Polas. Am I audible?
You need to be a bit louder. Move a little closer to them.
I'd like to thank all my seniors and welcome all the participants into this symposium on oxygen therapy in COVID. So in next few minutes, I will discuss about the modalities of oxygen delivery that you use in critical care unit. So if you look at the clinical management protocol for COVID-19 and the classification of severity, it has been divided as per the severity or requirement of hypoxia or breathlessness. So if someone has a mild disease, that means without any evidence of breathlessness or hypoxia. Moderate disease, saturation is less than 94, probably in the range of 90 to 94. And if someone has a severe COVID pneumonia, that means that along with the respiratory rate more than 30, the patient has a saturation less than 90 per minute. Now, why this 90 is an important component? So if you look at the oxygen hemoglobin dissociation curve, we can see that this saturation of 90 usually corroborates with a PO2 of 60 or nearly with the PO2 of 60. And after that, the oxygen dissociation curve decreases, the changes its character, and it becomes very significantly steep. Above 6 PO2 of 60, oxygen dissociation curve is reasonably flat. And even if you increase the partial pressure of oxygen, the saturation of hemoglobin increases insignificantly. But below 60, there is a significant drop in the hemoglobin saturation. And we all know that oxygen hemoglobin saturation is the main contributor in oxygen carrying capacity of blood. That's why we need to remember that our target saturation should be above 90. Now, how we can deliver oxygen in these patients? Because it's a viral pneumonia, so obviously they are hypoxic, and we have to give supplemental oxygen once they are less than 90. One is nasal cannula, one can be simple face mask, partial rebreathing mask, or non-rebreathing mask. This part has been discussed with Dr. Susmita. And most of these patients are usually treated or monitored in the ward. But one thing we need to remember, that doesn't matter where you are treating these patients, they need to be monitored in terms of oxygen requirement. And if there is a progressive increase in the oxygen requirement, they probably need a more frequent or continuous monitoring. Now, what is the problem? As Dr. Susmita already discussed in terms of non-rebreathing mask. But what is the problem with this mask? That you are using 10 to 15 liter oxygen with a variable FiO2 of 0.6 to 0.8. But we don't know what is the exact requirement of the patients, because it is very difficult to decrease the oxygen delivery in this mask or oxygen flow in this mask, because they need a certain amount of oxygen to flow to maintain the bag inflated. Somehow the Venturi mask is not that popular in critical care unit. Somehow we are more comfortable to decrease it with a face mask and then change to nasal prong once we come down to 6 liter of oxygen. Now, when you compare the pathophysiology of COVID-19 pneumonia, it is little different from any other conventional ARDS, whether it is because of pulmonary cause like a pneumonia or a systemic cause like a trauma or an intra-abdominal sepsis. And it has been identified very early by Gattunini when they have classified COVID pneumonia into two types. One is they called L type and one is H type. How are they different? That in L type, mostly the lung has a low elastance, that is the lung compliance is reasonably preserved. It has a low ventilation perfusion mismatch, that is because of loss of regulation of perfusion and by loss of hypoxic vasoconstriction. These patients are hypoxic and requiring a significant amount of oxygen. If you look at the lung, they are low lung weight, that means the alveolus are not consolidated, and the lung recruitability is also poor. But when the disease progresses and they land into a type H type of lung pathology, then the elastance is high, that means compliance is poor, lung weight, and high lung recruitability. This type H usually behave like a conventional ARDS. So our target should be to identify the lung physiology in the COVID-19 pneumonia and try to treat them accordingly. And whenever we are allowing a hypoxic patient to breathe spontaneously, depending on the severity of the disease, depending on the transalveolar pressure, the chances of self-inflicting lung injury because of variable pressure and volume during our breathing will be there. So that risk will be there whenever we are allowing patient to breathe spontaneously. So this is the CT scan of two patients. The first, both have a comparable PO2 FiO2 ratio, that they are comparably hypoxic. But if you at the CT scan, in the first patient that has a reasonably, apparently normal lung, significant amount of normal lung, compared to the second patient, which looks like a more conventional ARDS, when a certain part is totally atelectatic or consolidated, a part of the lung is probably recruitable or partly consolidated, and there is a very small normal lung, which we usually call baby lung. So now the ventilatory strategy or oxygenation strategy in these two patients cannot be same. That have been identified very early. Now, when you compare the outcome of in mechanically ventilated patient in these two subgroup of lung damage, we find that mortality is nearly comparable, specifically in the elderly population. And also, because of this large number of patients, the service providing in critical care also gets compromised in terms of quality and frequency of monitoring. Now, what are the modalities by which we can improve oxygenation? When we talk about oxygenation, one is oxygen delivery and another is improving oxygen delivery at the tissue level. Now, one of the very important component is awake pruning. Dr. Sushmita has covered to some extent. I just like to add one or two issues. Now, that in severe ARDS patient, prone ventilation is beneficial in terms of oxygenation has been identified very early. But after another 15 to 20 years of study and different uh, research work, in by 2013 in the Prosever trial, for the first time we have identified, we can document a significant advantage in terms of mortality. How it was different from the previous studies. One was that the duration was long. They keep the patient prone for more than 16 hours, and this patient was severely hypoxic with a PaO to FiO2 ratio less than 150. Now in COVID scenario, because of large number of patients, we have tried this modality also to decrease our chances of intubation. And we find that there is a significant improvement in oxygenation when the patients are prone. And there are studies which have shown that when we are supining this patient again, only 50% of these patients has advantage or retain the advantage of proning. That is, the improved oxygenation is persisting. But rest of the patients, there is no, the hypoxia again recurs back, and the PO2, whatever the improvement was done during proning, was lost. And this improvement does not convert it into a final outcome in terms of avoidance of intubation. So this prone ventilation, though improve oxygenation to some extent, but it in most of the studies, it showed that it cannot prevent intubation. But what is the problem with this? Because conscious patient, awake patient in prone position, it is very difficult to maintain. Patients are becoming uncomfortable, and it is very difficult to keep them in prone position for a very long time, like 16 hours. Most of the patient can tolerate at max half an hour to 2 hours, maximum 4 hours. After that, we have to change his position. So what we are doing presently, we usually change them from prone to a left lateral or right lateral or awake, depending on the response in terms of oxygenation. Now, next modality, which has become very popular in COVID scenario, is high frequency nasal cannula. Now, working in a cancer institute, we are using HFNC for some duration, nearly for 3-4 years, because we have a lot of patients who are post-transplant, who are severely immunocompromised, and we try to avoid intubation in those patients. Post-surgical patients, specifically the upper GI surgery, when you cannot give an IV, we try to avoid intubation in hypoxic respiratory failure, and we use HFNC in a significant amount. So you look at the components of high flow nasal cannula, it has a flow meter. Compared to the conventional flow meter, it can deliver a higher oxygen, that is the flow rate can be as high as 60 to 70 liter. It has a humidifier because of this high flow, it has to be very well humidified. It has a heated inspiratory circuit which has a control panel that we can control the temperature, mostly from 34 to 37. And the oxygen is delivered via nasal cannula, which is snugly fit into the nose. And we usually motivate our patients to keep the mouth closed, to develop a closed circuit. What is the physiological advantage? The high flow usually wash out the carbon dioxide from the anatomical dead space. Although the delivery it through an open system, the high flow overcome the resistance against expiratory flow and create a positive nasopharyngeal pressure. When the pressure is relatively low compared to the closed system like a NIV or a ventilation, it's considered adequate to increase the lung volume or recruit collapsed alveoli to some extent. And studies have shown the PEEP it can generate varies from 2 to 8 centimeter of water, depending on the flow of the gas, whether it's set to 40, 50, or 60 liter, and also depending on whether the patient is keeping his mouth open or closed. And also there is a difference between the inspiratory flow of patient and the delivered flow, which is small because we are delivering at a very high rate. And so the FiO2, which relatively remains constant. And because the gas is generally warm to 35-7 degrees centigrade and completely humidified, the mucociliary function remains good and little discomfort is reported. So this patient can cough out their secretion reasonably well. What are the other advantages? It can facilitate mucus clearance. It decreases the upper airway resistance, prevent upper airway collapse during inspiration. It decreases resistive work of breathing and reduce the patient's breathing effort in terms of pressure time product. And we look at the physiological components. We have found that with the use of HFNC, the PO to FiO2 ratio improves even with the delivery of the same amount of supplemental oxygen or PO2. And the minute ventilation, which is comparatively less when you are using HFNC, because the high oxygen flow usually replaces the dead space carbon dioxide with oxygen. So the minute ventilator requirement also get decreased. And if you look at the other physiological parameters in terms of end expiratory lung index and global respiratory index, peak inspiratory flow, peak expiratory flow, in most of the scenario, high flow nasal cannula has some extra edges over oxygen delivered by simple face mask. These are the all studies which was done in the pre-COVID era, and we are exploiting this physiological understanding in our COVID patients. This is the first positive trial for HFNC. This is called Frodelli trial, which is applied in acute hypoxic respiratory failure without hypercarbia in ICU patients, and they compare it with a BiPAP and supplemental oxygen. And they have usually avoid hypercarbia with this consideration that with high oxygen delivery, patients may start retaining CO2. And they found it is reasonably comparable with a non-invasive ventilation and better than standard oxygen delivery. And if you look at the 90 days outcome, they probably has a survival benefit. At least we can consider that HFNC is non-inferior in terms of pulmonary respiratory mechanics and oxygenation compared to non-invasive ventilation. And if you look at the compliance, it is definitely very much more comfortable for the patient when you compare with a non-invasive ventilation. There are multiple studies which have compared HFNC with either standard oxygen delivery or non-invasive ventilation with little bit heterogeneous result, depending on which subgroup of patients they have incorporated, what was the severity of the disease, and how frequently they have been monitored. But all those studies at least confirm one thing, that it is non-inferior to non-invasive ventilation in hypoxic respiratory failure patients. But can you use it in acute exacerbation of COPD? So this is a systemic review which shows that HFNC is able to keep PCO2 unmodified. That contrary to its conventional belief that it will cause an increase in PCO2, it doesn't happen in practical scenario. And while oxygenation is slightly deteriorated as opposed to NIV. And the work of breathing is reduced with HFNC by a similar extent like NIV, while it is increased by 40 to 50% when you are using only conventional oxygen. So at least it is non-inferior. Along with this, HFNC has been used in different interventions like bronchoscopy or any other intrapulmonary procedures. And we can extrapolate this information in COVID patients also. Even in a COVID patient, if you need to do a bronchoscopy, though we are avoiding it because of generation of aerosol generation, but if we need to do it, it can be a good modality to maintain oxygenation. Now next, whether nasal high flow oxygenation can be used as a pre-oxygenation method while we are intubating this patient. Again, we know there is an option that you can continue high flow nasal cannula even during the process of intubation and use it as a apneic oxygenation method. And studies have shown that it increases the apnea time, mainly because you can use it in the intra-procedure period during the laryngoscopy and intubation. And the chances of desaturation or the complication related to the procedure is less. And whenever the COVID pandemic has started, there was a significant concern regarding to aerosol generation in terms of HFNC and non-invasive ventilation. And we all know that both of these interventions are aerosol generating procedure. And initially, during the first pandemic, in the first wave, we were avoiding these two interventions in COVID positive patients, and we are going with a simple supplemental oxygen. But with our experience gradually and along with the literature, we identified that if we are wearing an appropriate PP, the aerosol generation by HFNC or NIV is not that significant. And above that, if you are concerned about this, you can put a face mask along with this HFNC to your patient. That will decrease the aerosol generation to a significant extent. And what is our data in terms of use of HFNC in COVID-19? It has been used in higher it can deliver high concentration and flow of oxygen, resulting in decrease in the anatomical dead space by preventing rebreathing and ensure positive end expiratory pressure, like pre-COVID era. And concern of aerosol generation is there, but high concentration of oxygen to the patient which cannot be achieved by conventional device. HFNC can reduce the requirement of intubation. It can decrease the length of intensive care stay and complication related to mechanical ventilation. It can help to provide apneic oxygenation in patients where you are doing airway management in terms of intubation. But as it is causing aerosol generation, this is better to do a negative pressure room, at least in a single room. Now, how are we going to monitor? Whenever we are managing patients with non-invasive modalities like HFNC or NIV, who are severely hypoxic, requiring 80 to 90% oxygen, we are always concerned that whether we are deferring intubation and causing harm to the patient. Now, even same for the HFNC, we need to monitor the performance of HFNC in an individual patient, and in that aspect, we can monitor the ROX index, which is respiratory oxygenation index. What we are doing, we are usually looking at the saturation, that is SpO2. We are looking at the FiO2 and the respiratory rate of the patient. And different studies have shown different cutoff. But at least if I take one of them, that ROX index, if it is greater than 4.88 after 6 hours, it probably is less than 4.88 after 6 hours, probably it indicates a high chance of HNC failure, and those patients may need eventual intubation. And as we can see that this is this graph, that if the ROX index is low with continuation of therapy, that with chances of HFNC failure and need for intubation is more obvious. But we need to remember this is not a very sensitive tool to pick up HFNC failure. So what I will suggest that if someone has a persistently low ROX index, even after HFNC therapy, at least they need a more intense monitoring in terms of oxygenation, in terms of impending respiratory failure, fatigue, CO2 retention, and need for invasive ventilation. We also need to remember the ROX index can be influenced by other parameters like what is the oxygen flow, what is the patient cause of acute respiratory failure, that whether patient has a superated bacterial pneumonia, what is the SOFA score of the patient, and what is the score ROX score at the 6 hour. Most of the studies has look at the ROX score as 6 hours and try to decide the need for intubation in this subgroup of patients. But these are mostly for pre-COVID era studies and in non-COVID patients. For COVID patients, sometimes we are continuing HFNC even the patient is requiring very high oxygen. Now, what about NIV? Now, we all know there are some international national guidelines in the pre-COVID era which has tried to streamline the use of NIV in critically ill patients just to decrease the chance of delayed intubation. We all know that if someone is an NIV and eventually get intubated, then the chances of respiratory failure, poor outcome is higher in those subgroup of patients. And what if you look at the indication, it can be used for acute hypercapnic respiratory failure like acute exacerbation of COPD. The data for asthma is not very strong, or acute decompensation in obesity hypoventilation syndrome, or patient who has it because of neuromuscular disease. In hypoxic respiratory failure, except acute cardiogenic pulmonary edema, the evidence of NIV is not very strong till the pre-COVID era, though we have used in ARDS and in pneumonia in mild hypoxic respiratory failure. In some certain special situation, we have also used NIV like post-extubation in weaning process, especially in patient with acute exacerbation of COPD, and also for a palliative patient or post-transplant patient when we have tried to avoid intubation because of their overall poor outcome. Now, what about the COVID pandemic? Even for the COVID pandemic, because as I mentioned, the outcome of intubated patient was not that great, we tried to avoid intubation in every possible modality. So like HFNC, we have also used CPAP in different modality, like with a face mask, with a nasal mask, full face mask, and also with a helmet. Probably helmet CPAP has get some more emphasis during this COVID era because they are more comfortable for the patient to continue for a longer duration, except the noise part. And a lot of international data are suggesting that they have used successfully helmet CPAP in this COVID patient for prolonged duration. And so the present suggestion, recommend, I will not say recommendation, at least I will say that present practice is to try to continue with non-invasive ventilation in COVID patients. If the patients are stable, oxygen requirement is stable, and patient is comfortable with HF, with BiPAP. But at the same time, we should be aware what are the signs, what are the contraindications for NIV failure. Like conscious patient is poorly conscious, agitated, not cooperative, feeling claustrophobic, any evidence of airway obstruction, any evidence of facial deformity because of trauma or any surgery. Patient has producing lot of sputum which cannot be moved out or cough out because of NIV, and the patient has a chance of aspiration. And we usually do avoid non-invasive ventilation in unstable hemodynamics like shock, retractable arrhythmia, and post-CPR patients. And studies have shown that NIV failure rate is mostly it is immediate and early. And so in the first few hours, maybe for 4 to 6 or a maximum 24 hours, most of the patients who are not comfortable in NIV may need a intubation. So this time we need more intense monitoring in this subgroup of patients. And studies have shown, in specifically for COVID patients, what are the risk factors for NIV failure, like age, means elderly, patient who has a high LDH or white cell count, that probably they're indicating that there is a severe inflammation is going on. They probably has a higher chance of CPAP failure. The percentage chance between the baseline on the CPAP application in ratio of partial oxygen saturation and oxygen delivery, that is the PO2 ratio, what is the final PO2, respiratory rates, and also we can use ROX index in this subgroup of patients. That also indicates the chances of CPAP failure. High FiO2 and male gender has shown significant NIV failure and need for intubation. And like age, gender, Charlson comorbidity index, which indicates the severity of the disease, and high lactate, YWC count, LDH, high CRP. Even in a multivariate analysis, they have shown that a high chance of NIV failure. Now, what about HFNC plus NIV? Can we combine these two to avoid intubation? Now, probably we are stretching these patients too much, but in certain scenario, you may need to do it, depending on the overall outcome of the patient or severity of the disease, also depending on the facility you have in your ICU. Do you have data? Yes, there are studies which has used HFNC and NIV to improve oxygenation. Those are mostly for a shorter duration to intubate a hypoxic patients. But can we extrapolate these data to COVID patient when we need to continue this for a longer duration? It may be, because this is one of the modality which shows that when your patients are apneic, when you are doing a procedure, HFNC plus NIV has a better edge over NIV alone. But if you are continuing both at the same time, probably HFNC plus NIV doesn't have much extra benefit. But so from this, at least we can know that these are the adjuncts or tools we have in terms of advanced oxygen delivery to your patient to avoid intubation in this subgroup in your ICU, specifically in COVID patients. So to conclude, whenever these patients are coming to ICU, probably there is a failure with conventional oxygen delivery, like nasal cannula or face mask or venturi mask, or probably these patients are little borderline or not comfortable tachypneic even with a non-rebreathing face mask with a reservoir bag. So there will be a very small margin of safety between maintaining oxygenation without intubation or decision about intubating in these patients. So that part indicates that we need more intense monitoring in terms of oxygenation, patient's comfort, and chances of impending respiratory failure in this subgroup of patients. Probably in a pre-COVID era, we usually do not stretch this type of hypoxic patients and intubate them very early. But in COVID, because of lack of manpower compared to the patient load, and also because of overall poor outcome in intubated patients, we are trying to avoid intubation in this subgroup. And these are the modalities we have at this moment, like HFNC, BiPAP, combination of both, or abictonic. We have to infuse them in a judicious manner, and most importantly, we need to monitor them closely so that we can decide about the right time of intubation. Thank you.
Well, thank you, Sudipto. So I think the move away from invasive ventilation to high frequency oxygen and NIV has been the greatest change in the ventilatory strategy that we have seen. Last year, the benefits of non-invasive ventilation has become very, very apparent. And as you mentioned that the outcome on invasive ventilation is so poor, and nowadays intensivists are trying to stretch non-invasive ventilation as far as possible and also combining high flow with NIV, as you mentioned. So thank you all the speakers. We have nicely covered all the steps of oxygen therapy escalation towards, except of course the most invasive methods of invasive ventilation and ECMO, which are very big topics to be discussed here. So we will now open this discussion. We already have a few number of questions here. So any one of you can take the questions. So we have a number of questions from Dr. Ramesh. We will take them in chronological order. So the first question was SpO2 target for mild, moderate, and severe disease. I think this has been answered by two of the speakers. So we have a range and it's not specific for mild, moderate, and severe disease. And the second question is when to suspect oxygen toxicity. We have dealt with a bit with oxygen toxicity, but are there any specific points when we can actually think about that the patient is having oxygen toxicity or at a very high risk of oxygen toxicity? Dr. Roy Chaudhary?
Yes, as we said, we don't want to really maintain a very high level of oxygen saturation in patients. If a patient who has been improving on oxygen therapy and then suddenly starts getting worse, feeling short of breath, and their oxygen demand is in spite of the oxygenation being 97, 98, suddenly starts falling, you need to suspect it. Also, if someone suddenly having hypotension on oxygenation, having been hypoxic for a very long time, those are things that will make you think whether we are dealing with oxygen toxicity or not. I'm not sure if there is any clear-cut indicators that will tell you that there are oxygen toxicity is happening, but your ABG worsening on oxygen should make you suspect it, and you should try and give oxygen and not try and increase the oxygen further in these patients.
So the message is that we do not have an exact point when we can say that this patient is having oxygen toxicity. So we have to play more on the side of safety and use the minimum oxygen amount of oxygen required. And if we have unforeseen consequence, even if the patient is on oxygen and then the desaturates or having an hemodynamic instability, then one of the differential diagnoses should be oxygen toxicity.
Dr. Palash,
and he is next. Sudipto, would you like to any or?
I'd like to add one point that presently oxygen toxicity is little bit theoretical, except in hyperbaric oxygen. When your patient is receiving hyperbaric oxygen therapy, oxygen toxicity is pretty theoretical even for a critical care scenario. Because in all form, in ward, in ICU, and everywhere, we have identified pretty well that you should not give oxygen to target a saturation of 100. We all target a saturation of 92 to 94, and eventually, even for an acute coronary syndrome, the initial concept was that you give supplemental oxygen as a therapy. Even for now, if the saturation is more than 94, all the recent recommendation is suggesting not to give oxygen even in ACS. So that we have already identified that target saturation for any patient is not 100, it is 92 to 94. So that oxygen, the patient with an oxygen toxicity is a very rarity. We rarely find a patient in our practice that who has an oxygen toxicity.
Right. So if we stick to the guidelines, then though oxygen toxicity is a possibility, it's going to be extremely unlikely that any patient will have oxygen toxicity.
Yes.
And when to think about hypercarbia? Any specific moments when we should consider hypercarbia in these patients? But what I have heard from intensivists that what we see in these patients is usually a very, very low carbon dioxide on an ABG. The SpO2, the gap, the patients have a reasonable SpO2, but their carbon dioxide levels is way too low. And one of the things that happens is that the oxygen dissociation curve is shifted to the left. So in spite of having a decent SpO2, the oxygen delivery to the tissue is impaired. So maybe hypocarbia is more of an issue.
Hypercarbia is, I think, when you're giving oxygen and if a patient starts complaining, the earliest symptoms they complain of is a little bit of headache. Headache is the most common symptom that earliest appears. And then after that, they can progressively start to become drowsy and flaps may appear. So suspect it if somebody is complaining of headache and then is progressively getting drowsier. So those are the simple things, bedside things as a medical student you would want to look for hypercarbia.
Okay. So the vasodilation caused by PtCO2 is going to cause a headache. Okay. So this is not exactly what we have discussed, but since we have time, what is the most preferable among dexamethasone and methylprednisolone? So maybe with this question can be slightly altered. There are several steroids that we can use, and there are several steroids which are being used. So is there a reason for us to choose any specific steroid over others? Or we can use any one of them in an equivalent dosage?
Do you want me to answer?
Yeah, sure.
So basically, because the recovery trial was based on dexamethasone, that was taken as the baseline, and methylprednisolone or prednisolone in equivalent doses are considered to be the same. So it is 6 to 8 milligrams of dexamethasone per day, which is equivalent of 32 milligrams of methylprednisolone orally, or 1 to 2 milligrams, 1 to 1.5 milligrams of IV methylprednisolone, which is 40 to 80 milligrams of methylprednisolone intravenous, and 40 milligrams of oral prednisolone. Any of these are equivalent and can be used based on your ease and your practices in your hospital.
Right. So would there be little advantage to something which we can administer once a day? I mean, they're probably the only things that would help us decide on which steroid to use. Efficacy wise, any. Okay. Do you want to add something?
So, as Madam mentioned, I fully agree with that we are maximum going as high as 2 milligram per kg. There is not much data suggesting that beyond 2 milligram per kg of methylprednisolone is going to be helpful. And more emphasis I like to give when not to use steroid. Like, it is better not to use steroid in the early part of the disease, and specifically when the patient is not requiring oxygen. And then the causes of steroid-related complications like hyperglycemia and superadded fungal infection will be there. So rather than the dexamethasone or methylprednisolone, as Madam mentioned, that both of us we are using depending on the practice, but should not go to a very high dose and try to avoid it when the patient is not requiring oxygen in the early part of the disease.
Correct. These are very important points. I think sometimes the steroid, we can describe the use of steroid as indiscriminate, too early, and pulse steroid therapy is being used. Sometimes the doses are possibly too high to give any actual benefit to that patient, and maybe being continued for too long. So these are the useful guidance that we have to keep in mind. So there is a next question by Dr. Chumki Dr. Paramita. This one is for: does a 6-minute walk advocated in an already hypoxic patient, does it not increase hypoxia? So 6-minute test is something that we often use. We anesthetists often use for fitness and for other purposes. Sometimes we over phone, when we consult somebody, we tell them to check saturation before and after a 6-minute walk. So what are the situations when we should tell them to do a 6-minute walk test, and what are the situations we should be cautious and refrain from telling them to do a 6-minute walk test?
No, if this patient is already hypoxic, can you know that the saturation is hovering below 90 or 92, you wouldn't actually take the risk of getting a 6-minute walk test on him. That is definitely true. But if this is a mild disease and you have the HRCT and you think that in a mild disease, this pulse oximeter reading is actually what you are, concerned. within inverted commas, because we have a lot of Chinese pulse oximeters. So then actually walk test have helped us, because there are various types of pulse oximeters and people do not know, the general population at large do not know how to see the, I mean, they are not doctors, right? They were not trained before COVID to see pulse oximetry at home. So, I mean, where they are in this situation where they're scared, etc. You know, a 6-minute walk test can help if you know for sure that I have had patients in home isolations where the HRCT shows it is a mild disease and the pulse oximeter was actually faulty. So in those situations of telemedicine where you know what you're doing, a 6-minute walk test can help you.
So, but I've heard it in
No,
a
but
patient
if
who
you
is
know this patient is
overtly symptomatic.
hypoxic on oxygen therapy, you would definitely not try a 6-minute walk test.
Right, right.
Dr. Polas,
The next question is,
just I like to add one point.
sure.
Regarding 6 minutes, it can give a good idea about the reserve of the patient. So suppose someone has a saturation of 97 and still is very much tachypneic and in distress. You look at it can extrapolate the PO2. As I know that 97 saturation can have a PO2 of 65, can have a PO2 of 105. So now if you do a 6-minute walk test and this patient desaturates from 97 to 90, you are well aware that patient is little borderline and you need more intense monitoring. Then the disease progress, he may desaturate and he may need an oxygen, he may need an admission and all those things. So even after 6-minute walk test, if the patient is stable, his saturation is still 95, 97, then probably the patient is in a safe zone and the monitoring can be a little bit relaxed in this subgroup of patients.
Right. So it has its areas of usage. So the next question is a little tricky in that sense that oxygen concentrator is a device which is sort of is meant for domestic oxygen use, people who are chronically oxygen dependent, COPD and all. But in these COVID times, we have seen since we are running short of oxygen, an oxygen concentrator is being used at home to give oxygen, and oxygen concentrator is being bought by clubs and societies where it is being, or it is used for somebody, then it is being used for somebody else. So I think this question is pertinent. Is there a way to make it sterile or make it ensure that it's not going to cause any cross contamination? So is there a way to do it? Do we know how to do it?
I don't think you have a way to make it sterile. And actually, everything which you use in the respiratory system are all disposable things. So the nasal cannula that you're putting it from the concentrator, you would actually dispose. So the machine, inside the machine, you cannot put it sterile, right?
Right. So of course, everything that is disposable has to be disposed
so that
of.
part is disposable, that you don't need to make it sterile, and a machine.
Like when you use an ICU ventilator, we use bacterial filters on both the inspiratory and the expiratory limb. And also there are ways to make the nerds sterile. There are some ventilators which nerds can be made sterile. So with a concentrator, we don't have that facility.
In a concentrator.
Yeah, we do not. Okay. So next one is again from Dr. Ramesh. I think what he wants to ask is if invasive ventilation is useful. So I think Sudipta, you already mentioned that the outcome of patients who actually go into invasive ventilation is quite disheartening.
Yes, I mean, that is all over the world. Probably compared to the last year, the outcome has improved to some extent, but still because of that increased number of patients, managing them in a restricted environment with a PP, less number of staff doing duty in PP for longer duration, and also because of the little unclear understanding of the underlying pathophysiology of the lung, the overall non-invasive outcome of invasive ventilation is poor. So if you can maintain the oxygenation without an invasive ventilation, at least present in most of the ICUs have tried to continue like that. And at the end, if the patient is not maintaining saturation with an HFNC or NIV or getting respiratory failure, impending respiratory failure because of they are getting fatigue, then we are intubating them as a last option. But whether it is little too late, that I don't know. That is very difficult to answer, but that is our practice.
So last year, when the initial ventilatory strategies is being decided, and almost everybody was being ventilated, when this disaster was unfolding in Lombardy, Italy. So most of the patients were being ventilated following the RDS net protocol.
Yes.
But after that, this Gattinoni published his studies showing L type and H type of lung, and then he advocated that people with L type of lung to be ventilated early, even before they become grossly dyspneic. We were talking about initially when we were thinking about people get that term called happy hypoxia was confined, became a popular word in use. So you have any experience with early intubation and ventilation in those patients who had a low saturation but were not overtly dyspneic? Any of the panelists, do you have any experience of that?
We have intubated those patients in the first phase because in the last year, because of the suspicion of aerosol generation, we are not using HFNC and NIB to that extent. That's why obviously when these patients are becoming dyspneic, they are requiring very high oxygen, they are requiring intubation. The problem is that whenever you are setting PEEP in a ARDS patient as per FiO2 PEEP contingency table, with increase in the PEEP, increase in the FiO2 requirement, you are giving a very high PEEP. Now, with the Gattinoni study, we understand these patients may be really hypoxic without any recruitable lung. So those patients who may be on FiO2 of 80%, but they may need a PEEP of 6 to 8. They may not need a PEEP of 18. But that was in our ICU, we usually do not set PEEP as per PO2 FiO2 ratio. We usually set PEEP as per the compliance of the lung. We look at the compliance of the lung and we put the PEEP according to the best possible compliance in the decreasing arm, de-escalating arm. So that was not a concern. But problem was that whatever the patients who require intubation, eventually whatever is the reason, the final outcome was not great. So that's why this year we are trying to manage patients with other modalities, and we are doing it pretty successfully. A lot of patients who are requiring 80%, 90% oxygen and HFNC, those are coming out without an intubation. And yes, again, those are getting intubated and having a very poor outcome.
Right. So HFN has been a game changer, and the point that you mentioned that the patient on ventilation puts the strain on the nursing care a lot.
Huge,
I mean, if you have
the nursing care,
yeah.
that is probably the main lapse in terms of outcome, because managing those patients round the clock with a PP is very challenging.
And proning long. I mean, we now know that proning for half an hour doesn't make really any difference. So
in prone patients, monitoring the numbers, picking up complications like when the pillow get dislodged, there is abdominal compression, there is not adequate ventilation. All those things are very difficult in those negative pressure units.
So
another thing,
message. Yeah, sure.
Another thing I would like to add, Polash, that we have seen certain patients which have been on the HFNO say around 14 days, 20 days. Later, these patients, nutrition is very important because later these patients are ultimately develop respiratory fatigue. Because HFNO at least gives, your mouth is open, so you can eat properly. Patients don't have that facility. But nutrition plays a very big role here, because if you are becoming weak and your respiratory fatigue is setting in, after 20 days, again ventilating these patients, they never come out. So late intubation is again one dilemma. So, the right, I would, in the first wave, we had taken out some patients out of the ventilator, but in the second wave, I don't remember anybody coming out of the ventilator.
Right. Dr. Raichodhuri, would like to add something?
Yes. So, we have Dr. Paliwal is our ICU head here, and we work quite closely. And our aim, the way we work here is that we give them, most patients they're happy hypoxics. There's no mentation problem. They're not terribly tachypneic or dyspneic. So we give them NIV and HFNC intermittently. initially, look at the PO to FiO2 ratio, and if it is still below 100 or 95, then we go for early intubation, and patients do come out if you are early intubating them, if they are not in very severe gross ARDS. And as you rightly said, the biggest challenge here becomes proning and the nursing staff proning them. And most patients are above 100 kgs and all that, but the nursing staff have been a major game changer here in proning 18-6, 18-6, at least 5 cycles for these patients. So if somebody is not improving beyond 5 cycles of ventilation, we know that they're not going to do well. But if we consider proning, we consider early if we consider intubation, we consider early intubation after a fair amount of time on HFNC and NIV on the patient, rather than late intubation. As Paramita Di said, those patients don't do well at all.
Right. So I think we have had a very exhaustive discussion on this topic, and it would be helpful for all of you to take your clinical decisions when you are facing such a dilemma. The next question is from Dr. Shakil. He asks, how can we calculate oxygen consumption of patients on NIV and ventilator? Is there a way?
Why you want to calculate oxygen consumption in vent?
Yeah, that is a question that I would like to ask. But anyway,
in terms of oxygen consumption, we can do that. We can look at the PO2, we can look at the SaO2, and we can, from the venous oxygen and arterial oxygen, we can look at the cardiac output, and we can eventually calculate it. But does it going to help? Does it going to influence our any clinical decision or management decision? One thing I would like to mention, that can you monitor the FiO2 in a NIV? That can be sometimes really challenging. In ventilator, when the patient is intubated, you know what is the FiO2 you are delivering. In NIV, non-invasive ventilation, if you are not delivering it through a large ventilator, big ventilator, when the FiO2 can be fixed, mostly oxygen is delivered through a cannula to the machine. Either it is connected with the face mask or it is connected to the tubing at any certain point. In that situation, what is the exact FiO2 patient is receiving is very difficult. We need to remember this can be predicted with a certain accuracy if we can look at the patient's minute ventilation and the oxygen delivery. Suppose we are giving 10 liter oxygen and the patient is having a 20 liter minute ventilation, then probably the FiO2 is around 50%. But there is lot of catch, lot of ifs and buts in this, because what is the amount of dead space ventilation, what is happening to the oxygen when we are delivering, where we are delivering the oxygen, at the end of the tubing or at the face mask. Those things will influence the final FiO2. But eventually from this, we can at least predict or we can monitor the oxygen requirement in this patient. And regarding in terms of consumption, the only clinical significance in terms of oxygen consumption is that in severe sepsis, when there is a mitochondrial failure, then even if you are giving a very high oxygen, patient has a poor evidence of tissue hypoxia, but the systemic venous oxygen concentration is still very high. That indicates tissues are not able to utilize oxygen and the whole oxygen is coming back to the venous system. That indicates failure of the oxygen utilization at the tissue level, and most of these patients do very poorly. Most of them will die because of severe tissue hypoxia. And otherwise, calculating oxygen consumption is, I'm not doing because it is not going to influence my clinical decision.
Okay. So from my experience as an anesthetist, I can tell that to measure oxygen consumption, you need to have a very precise idea about the minute ventilation and both the inspiratory and the expiratory oxygen consumption. So it's not possible with these modalities. Maybe theoretically possible if you have a very tight fitting mask and a ventilator where you are sampling both the inspiratory and expiratory. But clinical utility is less. And as Sudipto mentioned, that I don't think we no longer do this mixed venous oxygen saturation in this patient. Like some patients we used to do earlier.
Theoretically, we can do. If we plan to calculate, we can do that from those numbers.
Yeah, if we want to do it, then we do it. But the clinical utility is not much. Right. Amnadi, you can speak. I think raising your hand. Yeah, please.
Yes, Palash, I have a very foxing problem. This WBDF has started this helpline, and unfortunately, I am on that. So I have a patient who's 60 years old. He had temperature for a few days, just 2 days, and then he went to see a local doctor who put him on the entire gamut of medicines prescribed. And he was on these medicines for 5 days. He's perfectly all right. He's going around. He's maintaining a saturation of 97. Now, the same person advised a CT scan for him, chest CT. Now, this CT says a CTSS of 10. This gentleman who is quite literate and well versed with what is happening in the world. So not, that has made him very panicky. Now he's asking me, do I have to keep an oxygen cylinder at home? Is this, am I going to worsen and things like that? So I am asking Paramita, do you think you have such patients, who are going around eating, drinking and doing everything, but they have a CT which has a score of 10?
Ma'am, thank you. Good evening. It was a pleasure talking to you today. No, ma'am, I think these are patients who are actually panicking. So clinics is more important than anything. That you have to understand. And if his clinics are fine, over exaggerating things is not helping actually. So yes, a close look at him every day, checking him on telemedicine, etc., would be definitely a good idea. But stocking up oxygen for that matter, where his saturations are perfect, does not make much sense about it.
Sushmita Di, I would like to add something to this question. I mean, when you do prescribe an HRCT, I mean, are we prescribing it, too many times?
Yeah, so that's a very pertinent question, and we face this on a daily basis. In this patient, if you were seeing him, he would be an ideal patient to do a 6-minute walk test to see if that 97% is falling below 3% of his resting saturations or below 94%. And if that patient had a 10/25, then I would advise them hospitalization, because that is the earliest you would be catching somebody going into hypoxia, and these could be managed in the ward level. Having said that, CT chest should not be done on everybody regularly. The only indications of a CT scan would be, at least if they are hypoxic, they get getting saturations below 94%. If they are 6-minute walk test shows that they are dipping downhill, or it is beyond day 8 of their illness and they are coughing significantly, because a dry cough is pretty much a good indicator that the SARI is developing. Other than that, regularly CT scans must not be done, because A, they are not confirmative, and B, they make people scary. Lots of times people are being treated on the basis of their scans rather than their clinical situations, and which is why so much of steroid, we need to limit that completely.
Right. So this is very important. And Amrati, how long the patient is symptomatic when the COVID was diagnosed? I think that would be an important question here. Correlate CT findings with the duration of the disease and the period when the patients start to go downhill suddenly.
Palash, actually, this is a very physically fit patient. He does his yoga even every day, and he maintains a saturation of 97 and 98. I do not know why the physician advised CT. And even in that report, it says CTSS 40/10. I don't know what this 40 figure stands for. I think 40/10.
Okay,
10/40. I think there's something fishy there. There's something fishy there.
No, it's not 10/25.
It's not 10/25, it's 10/40. That's what the report says. He sent me the report. He couldn't send me the plate, so he sent me the report. Okay. He said, "Madam, this is what he said," and he says it's 10 and you have to be very careful and you have to store oxygen, etc., etc. So what I told him is you keep on checking on your saturation. Any point you feel that it's dipping or feeling tired or something is happening to you, you're a learned gentleman, you'll find out something. So just forget about it. I don't know whether I'm right or
Right.
not. That's what I'm asking Paromita. Because I don't deal with these patients normally like you people. But somehow I've got into this thing helpline, and people are referring to me and they're very happy with me. I don't know why. So Paromita, you think he should keep an oxygen in store?
No, ma'am. If this is not clinically indicated, unnecessary hoarding of oxygen is making life worse for people who really need it. We have seen
And
people succumbing without oxygen. I have seen lines of, ambulances where we couldn't admit the patient succumbing in that ambulance. It is very pathetic, ma'am. And the second wave, believe me, ma'am, we have seen people 19 years,
horrible, yes.
1-year-old dying. I mean, it's very sad. It's very sad. It takes a toll on your heart.
And this is particularly happening in the periphery. This
This is
gentleman,
specifically happening in the second phase, which was much less in the first phase. And another major difference that we are seeing in the second phase is that there is a lot of secondary bacterial infection, which was quite less in the first phase. We did not
and
have to actually see so much of secondary bacterial infection in the first phase. So that part, post-COVID complications are also part, say, 1/4 of your population nowadays.
is it because of this indiscriminate use of steroids? Steroids are immunosuppressants.
I see a lot of people giving steroids at home, which is never indicated in ICMR.
And steroids are immunosuppressants.
That is what I emphasize. ICMR never told you to give oxygen at home. ICMR never told you to give an intravenous steroid.
I think a couple of the therapies at home was an evil of necessity, because simply the healthcare system could not accommodate.
Yeah,
So
because we could not
it had to be started out.
accommodate, we did whatever way we could
Yeah,
have
it was
helped
difficult.
them. But then again,
Well, let us
this
come
is
back to the
also
questions
true.
again.
Yeah.
Right.
This
With
is
the leading
also
bit, let us
true
come back to
that-
the questions again. So we will, I think 2 more questions are on invasive ventilation. We have covered invasive ventilation, when to go for it, and the situations when ventilations can be useful, and all these stuffs in detail. So there's one question for Dr. Jyotsna Goswami: how to avoid oxygen wastage during home oxygen therapy? I think we can just say how to reduce oxygen consumption, whether at home or at in the hospital ward. There was an interesting forward from some, I think, somewhere from Chennai or something. So any one of you, how do we reduce oxygen consumption? Anything that we should keep in mind to reduce oxygen consumption? I think we had one pointer already in the discussion, that sometimes patients are themselves dialing it up.
Every
So-
night I see patients, they actually, even doctors, we have a lot of doctors admitted in Disan, and every day night I see patients turning back, putting the flow meter up and going to sleep.
So Udhikantu no doshaya, so that's their philosophy they're following. So that's one of the things to prevent the patients from dialing up the cylinder. So I think in case of home oxygen delivery, the what should be the guideline? If somebody has to be given an oxygen at home,
Fitting the mask as well. Fitting mask is also one issue where you have a leak, so you're wasting oxygen, in fact. So fitting mask is another thing where the face mask should actually fit the thing. And
Right.
what happens is when the patient takes it off to eat, okay, you put a nasal oxygen, and
Turn it off.
you will
Turn it
see
off.
patients having a face mask on their head. Okay. So many funny things happening, but then
Okay.
a lot of oxygen, actually the fear of death, the fear of hypoxia is leading them to do all this. In fact, a few patients who are on dual oxygen therapy, and they are doing well. If you see that, the pulse oximeter reading is 98, even then the patient will tell you that I'm breathless. The ABG shows that the oxygenation is better, but the patient will say I'm breathless because he's habituated to having that, more oxygen. So it is a mental dependence that's happening, and where
Right.
we need to counsel.
So they have to be taught quite well regarding exactly what to use, and maybe a little bit about the drawbacks of using higher oxygen. It's
Counseling goes a long way, because
counseling is a very, very
Madam,
important
আপনি তো
piece.
রাত্রে থাকবেন না, আমি মরে যাব।
And also, I think they need to be told that they should never target a very high SPO.
Yeah, I know.
Yeah,
They
it
have
came
a fear,
from
especially at
one of
night.
the chats is that the patient relatives are using their own oximeters and trying to dial up the oxygen till they are not saying 9800, like it's a math test kind of stuff. So
No,
that's not it. They need to be told that that's not something that we're trying to do. Right.
No,
And
one
next
is
question.
they feel if they sleep, and that
No, fine, but we have to try. We cannot just leave it at that. Some people will sort of change their habits, not all. So how to set pressure support on CPAP mode? I think we're talking about
So,
anybody, Parmitadi?
when we are setting CPAP or BiPAP, so basically we need set two pressure. In CPAP, we are just setting the index EPAP, and when we are setting BiPAP, we are adding an inspiratory pressure along with the CPAP. So we put usually what we do, we put the mask on. We start with a conventional one of 5 or 6 centimeter of water, right, in CPAP. Now we see whether patient is able to trigger every breath on the ventilator. So ideally, if the CPAP is adequate, the patient should be able to trigger every breath. If the CPAP is not optimal, patient's respiratory effort may not convert it into a breath. So if that is happening, then the CPAP is optimal. And mostly we usually require a CPAP of 6 to 8. In very rare occasion, it can go up to 10. Beyond that, it usually doesn't tolerate with a non-invasive ventilation.
Okay. Next, what are the general advice for COVID patient discharged from hospital in requirement of chronic oxygen therapy? Anything other than the usual advice that we give them?
Routine one.
Routine advice. So respiratory exercises, maintain a healthy lifestyle.
Yes.
Take the drugs in time. Nothing specific.
I think spirometry does help a lot, and I think those breathing exercises, spirometry.
That I think we are prescribing to everybody who is going. Everybody who is going home after COVID is getting an advice of respiratory physiotherapy, which includes spirometry that they can do at home. So anything additional for patients who would require a bit of oxygen therapy? I think, are we discharging patients at home who require chronic oxygen therapy at home? I think patients are coming back later who develop significant pulmonary fibrosis. Then it becomes pretty severe.
Mostly the recommended
discharge. So anybody who is requiring oxygen does not fulfill the discharge criteria.
Some are going home with a DORB or discharging as medical advice, and they are saying we'll maintain in the room with oxygen. And then we are suggesting for a conventional around 90 target saturation.
Right. So if they are on oxygen, the only thing that would tell them that what kind of saturation they should attempt.
Yes.
Should not try to overdo it.
Yes, we have had patients who have stayed in our hospital for 2 months, and we did discharge. They were the policeman, in fact, the assistant commissioner of police. He healed by fibrosis. He went home on an oxygen therapy of 2 liters of oxygen. And but no extra, and nothing extra he needed, and he didn't need anything extra, except that we tell them you should not actually do any strenuous exercise to the point that you should not have constipation as well. He used to desaturate if he had constipation, that I do remember. So stool softeners is something which if you're healing by fibrosis, you should be thinking about.
Right. Well, that's an interesting point. Next question is that the patient is in prone position, but still the saturation, even after keeping the patient in prone position for significant time, saturation is 89 to 91. So when is the ideal time to start on oxygen?
Eventually, this patient will desaturate once you turn even. He cannot tolerate proning for indefinite period, maybe an hour or so, maybe 2 hours, at max 3 hours. Eventually, he will require to be supine position or lateral position. Then you have to give a supplemental oxygen. See, again, the amount of oxygen is secondary. The point is to maintain optimal saturation so that there is no hypoxia induced on the organ damage. So targeting saturation of 88 to 90, 92, whatever we are targeting in your practice, and that should be the parameter to monitor rather than the amount of oxygen. Amount of oxygen the patient is improving or deteriorating. If someone is requiring 6 liter, now requiring 15 liter oxygen to maintain saturation 88, that means he or she is deteriorating. They need more intense monitoring, maybe another modality of oxygen delivery, maybe some therapy or something. And until saturation 90, that means he is improving. So that patient probably is going to do better in due courses. So that's the point. Otherwise, targeting a saturation of 88, 90, 92 is eventually doesn't matter. But need to monitor that on a regular basis, and targeting those saturation with whatever the oxygen that person is requiring is important.
Right.
I
The next
have
is
a
on
question.
this.
Dr. Shushmita, this is for you. We do see this sudden increase of oxygen demand at times, right? The cytokine storm that we are thinking about, since tocilizumab is not available right now in the market, are you using bevacizumab? What are the results?
Okay. Yeah, no, I have not used bevacizumab on anyone so far. What we do is, if tocilizumab is not available, we increase our solumedrol dosage to 120 milligram, and at best 125 BD for 48 hours. If there's no improvement in that, then we just persevere and cut back to our 2 milligram per kg body weight of solumedrol.
So you've not used bevacizumab or itolizumab, right? So Dr. Shudipta, what is your experience?
I've also not used anything beyond tocilizumab. And steroid practice is exactly same. If we are not having tocilizumab, we increase the steroid for a shorter duration, maybe 24, 48 hours, not responding, or then we come down to again at max 2 milligram per kg.
Thank you.
Right.
Some people are using UTRIP, ulinastatin. What about your experience of ulinastatin? Shushmita, any remarks on ulinastatin?
Not used on anyone.
Can I ask one simple question?
Yeah, sure.
Palash. So one patient today actually called me as I am also on helpline. She was having 2 days temperature, and she then recovered. She didn't have any other symptom. But 12th day again she got the temperature. That day her CRP is raised 25, and RT-PCR she did. That was again a positive on 12th day. So the question was whether it is continuation of the COVID or what happened. Why?
So it is not very uncommon to see patients who have fever in the initial half and then for 2 or 3 days won't have fever, but again
12th day fever on 12th day.
Yeah.
This is the classical humpback fever.
Yes.
Double hump fever.
That's right. So they will have again, which is not uncommon in viral fevers at all. Also, if you're entering the immune phase, you can have immune fevers as well. Apart from giving them paracetamol, unless the CRP is jumping significantly or they are desaturating, please don't go into giving them steroids. And RT-PCR, once positive, should not be repeated again, because it is just a genetic, material of that virus staying. It doesn't indicate that the viremia phase is persisting. Lots of people, take a lot of, pride in saying, I am RT-PCR negative. It is very difficult to explain to them that it means nothing at all whether you are RT-PCR positive or negative beyond the 7th or 8th day, when your viremia has gone, and whatever has to be done is between your body and whatever the virus has left behind for it to interact with. That is all that it means. So if they are desaturating, CRP is jumping significantly, and there are new radiological infiltrates, then treat with steroids. Otherwise, simple paracetamol and excluding any secondary infection is all that we would do.
Shall
So
I
we would just sit
advise the
tight.
CT scan if fever is
If,
there?
no, ask them to look at their
Saturation
saturation
is
level sitting.
normal.
So no need to do CT scan. Ask them to do saturation at rest and 6-minute walk test 3 to
Yeah,
4 times a day for
that
2 days.
was maintaining, but CRP raised to the 25 on 12th day.
CRP is 25, not significantly raised. I would clinically monitor this patient.
Okay, thank you.
Any guideline for step down of oxygen therapy? Or just maintain the patient at the lowest oxygen that
Targeting a
That would keep it
saturation.
target saturation. Yeah.
Yeah.
Simply follow your instincts, and if the patient maintaining target saturation, keep lowering it. The patient saturation falls into it. Right. How to sterilize the humidifier and what to put in it? Distilled water, saline, or anything else?
You can never put in saline in the humidifiers. And actually, you should put in sterile water, which becomes a bit difficult to available all the time. It's not available all the time, but you have to put in, you have to be as sterile as possible. And those glass beakers that we go on keeping water, those needs to be autoclaved as well. If you give them for culture, like the air in the OT we give for culture, right? So like if you give them for culture, you will see that they do contain uh, uh, Acinetobacter, etc. So they are places where they are sources of
833.
contamination.
So, what fluid in the hospital that I put in? The only way I know that there is sterile water is the water for injection that comes in milliliter break
Sterile
open
water
plastic bottles.
or distilled water. Or distilled water,
Or distilled
anything that
water.
has salt, anything that has salt in it, when the when the oxygen, the water evaporates with it, it is going to leave behind the salt into the humidifier
Residue.
and also clogs up the the tubing that goes into it. Therefore, anything that has salt in it should not be used. Distilled water or sterile water is what should be used.
Specifically so in the HFNO, if you use anything salty in the HFNO, you will spoil your HFNO.
Next one is about an oxygen concentrator. There is a filter that should be cleaned or changed and sterilized. The auxiliary flow meter. I'm not very clear about this question. I think there is a filter. I'm not sure about, but anything that is an air intake has a that just needs to be cleaned, or any other filter. I'm not aware about oxygen concentrators. Paramita, any other filter?
No, actually, you don't get the filters once again. Like it's not like your AC, you can wash them and put it back. So that is not actually feasible. Like your BiPAP machine, can you change your filters in the BiPAP machine? You do use your BiPAP machine on multiple patients, right? So can you change the filters? The answer is actually practically.
So I think one very important issue about filters is that is the exit air getting back into the patient. This is one issue about cross contamination. If it is not, then we do not have to worry about cross contamination if we change everything after that machine, like the administration circuits and all that stuff.
Yeah, the disposable.
And there is a crude filter that everything disposable is actually disposed of and a new set is used. And the other issue is the purification of air that is entrained in that machine. There is a crude kind of filter, like a thin sponge or something, that just needs to be cleaned. So I think that's about it. Patients doing well, but a good oximeter saying oxygen saturation 90. What to do?
Okay.
So this is still not happy hypoxia, but going towards happy hypoxia. Not having distress, but at borderline hypoxia. So I think that as per the guidelines, we have to do something if the saturation falls below 94.
You can check with an ABG whether it is really falling or not, because
We will assume that the oximeter is good. I mean, patient at home or something. I mean, this patient can be at home. We can't do an ABG. Or maybe in a rural setup where you can't do anything. We start the patient on oxygen. Start proning. Anything else?
proning, definitely.
Yeah.
Yeah.
So if somebody is saturation as sitting is 90%, as you've said, assuming that the oximeter is good, then they definitely need to go get to hospital first, get an imaging and a arterial blood gas done, and see whether because anything below 92% qualifies for hospitalization. So getting into emergency and checking out whether they need hospitalization or not is most important.
Right. So this is the best time to get into a hospital. Okay, Shakil, your question is still not very clear to me. Consumption of manifold. Manifold we have in anesthesia machine. I'm not sure what exactly you mean. Please. Which manifold are you talking about? I mean, how much oxygen is there in the oxygen bank? So there we have a manifold, or we have a manifold in an anesthesia machine. So please retype your question. We'll try to get it. Any role of methylene blue in COVID patients? Now you're into the murky areas.
No,
I think this is one of the conspiracy theories which says that, well, it's a, this is what my take on this thing is. Like, we are not only measuring with a pulse oximeter, but we are also doing an ABG. So when you are doing an ABG, we find that the oxygen tension, the partial pressure of oxygen in the plasma is low. So that tells us very clearly that there is a problem of oxygen diffusion across the lung membrane, whatever it is. Problem with perfusion, problem with ventilation, possibly both. So it's not a hemoglobinopathy that is being touted this thing. So methylene blue is not going to be of help. Okay, oxygen consumed by ventilators. So I think your question sort of is, if a ventilator runs on oxygen, then often the driving gas is also oxygen. So how much oxygen would a ventilator consume? Is there a way? I'm not aware.
Basically, what happens if there is a compressor, then probably he will draw air from the atmosphere, and then try to maintain the minute ventilation with the air and the oxygen delivery with the mixture. So suppose it will depend on the minute ventilation of the patient. Consider one patient has a minute ventilation of 10 liter. Now his FR2 requirement is 50%. So out of the 10 liter, it have to be 5 liter have to be oxygen per minute, and rest 5 liter that will be drawn from by the compressor from the atmosphere. Or if you have a compressed air, then it will draw 5 liter from the compressed air. Am I clear?
Right.
I have a
We
question for
know
Dr.
basic theory,
Sudipto.
but
Yes, ma'am.
Dr. Sudipto, since you work in a cancer hospital, what are the microbes you're finding in the secondary bacterial infection? What is it commonly that you're getting?
The ESBL and carbon-resistant bugs are reasonably same. But as you mentioned that in the first wave, in the last year, those incidence was decreased. Somehow it is again coming out. It is again increasing this year. Maybe because of the increased number of patients, because of workload, we have to expand our ICU, we have to increase the number of bed in the COVID ward. So maybe that is the reason. And again, the ESBL, carbapenem-resistant bugs, all those things are coming or increasing. The new addition is the fungus.
So in a secondary bacterial infection, are you routinely giving the antifungal like voriconazole, etc.?
No. No.
I think voriconazole is a risk factor for
right.
mucormycosis.
So that's my question. So are you doing the galactomannan, etc.?
Yes, yes, we are doing galactose and aspergillus in high-risk patients.
Aspergillus, and what are your results usually coming up to be?
So the galactose and aspergillus, we are getting pretty significant number of patients we are getting positive. At least in last few months, it is nearly 25 to 30% patients. We are getting very high galactose or aspergillus PCR positive.
Right. So I come back to Dr. Krishna's question that when this fever comes back on the 12th or 14th day, probably doing a galactomenon can also help. You know, secondary bacterial infection or secondary fungal infection.
I think that
can
person
be
is in a community setting.
Probably it is too early to think of a fungus.
Yeah. Community setting, not getting a steroid.
At home.
Not getting
Yeah.
steroid,
So
yeah.
No, many people
chances of
actually
that would
are
be
getting
less.
steroid at home. They did not get a
No,
hospital.
she didn't get the any steroid, she said.
So they did not get a hospital grade and they got steroid at home. On
Yeah,
the 12th day, they
that-
came back with fever, and we are getting those galactomenons, and we are getting people who were treated at home because of lack of beds, and they had a fungal infection. Yes,
I got one patient call.
I think 3-4
Patient
days
even
of steroid fungal infection would be rather rare occurrence.
Krishna, they mentioned after the 14 days.
no fever, but no, she didn't get any steroid. But one of my patient, I saw prescription. She said just fever, and her physician started steroid even without RT-PCR.
Yes.
First day.
Steroid at home. That's not
At home without RT-PCR. After 2 days, she did the RT-PCR, but she was getting steroid from the first day. The another patient. Now on 5th day, if she's asking what to do, shall I stop the steroid or she should complete the steroid dose?
It all depends on the availability. If you look at the RT-PCR report, sometimes it is taking 3 days to come.
No, but from the first day of the fever.
Yes, ma'am. Problem happens that they are accessing whatever is easily available.
Yes.
Oxygen is not available, hospital bed is not available, RT-PCR report is available, not available. Okay, steroid is available, let's give steroid.
But if the patient has no other symptoms, shall we stop the steroid after 5 days also, or what?
Absolutely not recommended. Absolutely not recommended. But that's happening. We are seeing patients who has already received 5 days of steroid and doxy and ivermectin and everything, every possible medicine, and then they are coming to the hospital. Not recommended, but that's happening in the community.
Can the patient is on oral steroid? Can we do shift to the inhaler? What to do with the patient?
No, but the mechanism of action will be different, and inhalers, there are studies.
Can we shift to the patient to the inhaler as a physician?
Neither is required at this moment. It just needs symptomatic therapy and monitoring, because a lot of studies have shown in the initial viremia steroid, the duration of viremia, duration of viral shedding will be prolonged, and the chance of having poor outcome is high. So it is better to avoid steroid in the early phase unless there is an indication.
Inhaler also?
See, if you yes. If you look at our previous practice, we have never used steroid in viral pneumonia, never. If you look at the outcome of all the ARDS patients, they always do poor with steroid, always do poor in viral pneumonia. So that was a no-no. Viral pneumonia causing ARDS, steroid is a no-no. This is the first time we are using steroid in a viral pneumonia. So it is strongly recommended not to start steroid very early.
One question, one thing that needs to be answered here is that if the patient is like that and received steroid for, say, somewhere between 3 to 5 days,
yeah,
can this steroid be abruptly stopped?
Yes, my question is that.
Yes.
Can we stop steroid?
Yes.
It depends on the dosage of steroids. If you are using
full dose, 32
patient
milligram
gets
of
full dose.
Medrol.
32 milligram, you cannot stop right away.
Yeah,
Yes.
Shushmita ji.
If anybody is on Medrol 32 milligram, prednisolone 40 milligram, dexamethasone 8 milligram, you can stop anytime straight away before day 10. And you don't need to taper. So you just stop it and then don't go ahead and taper it.
Okay.
So this is a very, very important take-home message. Please take note, because I have seen prescriptions, patient got steroid for 5 days, then got a tapering off for 15-20 days.
Yeah.
So the patient ends up receiving steroid for 3 weeks.
21 days minimum. 7.
So So this is a very clear-cut message that if you are using the standard dosages up to 10 days, you can just stop. Do not use a tapering dose.
Another message I would like to give, actually, we don't like to give steroids, right? We actually are very afraid to give steroids until unless we are pushed to the, my back is on the wall.
Outside, steroids are being used indiscriminately.
Yes, that is where
because
I
it brings down the fever.
Yeah.
I actually, one of my home quarantine patients came back to me 7 days later saying, "Madam, you did not give me a steroid. I went to another GP and they gave Medrol 16 milligram twice daily,
So
and my fever stopped."
Let's not discuss about wrong practices. What we need to
they actually,
we have to talk from here is what we should do. So anybody listening to this discussion,
has one option. They say that with steroids my fever will go. So that is why
they know the name also and they take themselves.
Medrol 16 is a common name.
I think there is one very important question here: is the clinical radiological dissociation in COVID pneumonia? I think this is something that we need to touch upon. Sushmita?
Yeah, so basically what happens here is patchy pneumonia, which is ground glassing, as we would see in acute interstitial pneumonia. It starts as acute interstitial pneumonia, and there is a lot of VQ mismatch in these patients, as we would see in any acute interstitial pneumonia, which continues progressively to worsen. The patches become bigger, they become more confluent, and then they turn into, what do you call it? What is the word for it? See, I'm forgetting. What's the word for it? They become more, they become more confluent pneumonias, which are organized pneumonias. And that is why you find a lot of VQ mismatch, mostly affects the dependent parts of the lungs first, which is the reason why awake proning helps. The mismatch happens a lot because in autopsy cases, they have found that there is a lot of micro and macro thrombosis also, which is a harbinger of diffuse alveolar damage as well as acute interstitial pneumonia. So the two together cause significant ventilation as well as perfusion mismatch in these patients. The more the diffuse alveolar damage, more the worsening of the ventilation perfusion mismatch in these patients happens. So it is like an acute interstitial lung disease, which is on top of that ongoing progressive diffuse alveolar damage and worsening microthrombi, which worsen and make the patient as organized pneumonia, is what is the pathophysiology that has been found in autopsy patients of most of the patients that haven't made it.
Right. Sudipto, anything?
Yes, I agree with ma'am that these patients, as I shown in my presentation, that initial CT scan shows them mostly patchy involvement and hypoxia is very, very disproportionate. This disproportionate hypoxia is mainly because of VQ mismatch. And that's why our ventilatory strategy or oxygenatory strategy is variable. And this radioclinical dissociation in terms of hypoxia is the cause of different ventilatory strategy or different oxygenation strategy in this subgroup of patients.
Right. So let us move to the next question. This is also a very important one, slightly different from what I've discussed. The role of oral monoclonal antibodies in COVID. I think one set of monoclonal antibodies have been approved for use in India. I don't know whether it is still available. Something that was developed by Regeneron and being produced by Roche and probably will be marketed by Cipla. I think the NHS has also started a different set of antibodies as a first-line treatment in COVID positive patients. So do we have any experience of using monoclonal antibodies in these patients in our country? No. But anyway, from the literature.
Not yet, but mild to moderate cases, I think we will shortly be receiving, especially Roche is trying to do a lot of clinical trials in lots of hospitals, especially in patients with mild to moderate COVID.
Actually manufacturing what was developed by Regeneron, that one, that President Trump, yes, the cocktail that Trump received.
Yeah.
Okay, so we'd probably have a better answer a couple of months down the line when clinicians would have a first-hand experience with using this thing. Right. Dr. Bhomik mentions that patient should be counseled that oxygen is also a drug. Certainly, I think it's difficult to impress upon them, but that is something that needs to be done. Dr. Poddar wants to ask a 6-minute walk test in Indian scenario for isolated COVID-19 plus patients. I think we have discussed about that quite well. We have discussed about happy hypoxia also, when to, even in patients who have an happy hypoxia, how to start oxygen, and maybe in some cases we can also ventilate them early. Okay, so we come back to that oxygen thing again. So what he wanted to ask is the oxygen consumption. So this flow rate that you set on a ventilator is the maximal flow rate. Like the flow rate of oxygen through the ventilator is episodic. And when the patient breathes in and we are supplementing, we are administering a breath, the flow of whatever we are giving, the gas mixture is uneven. So it rises rapidly, produces a peak, and then tapers off, and then exhalation proceeds. So somebody who is breathing hard would require a higher oxygen flow. So if you set the maximum flow at say 40 liters a minute, that does not mean that you are consuming oxygen at 40 liters per minute. It's much lower than that. But the ventilator is capable of delivering a flow rate of up to 40 liters to compensate when you are breathing in for a very short period of time. Sudipta?
And Dr. Paul, just see, whenever we are setting a ventilator at 60 liters per minute, that is the flow rate. That is not the volume of gas ventilator is delivering. We need to understand. We have set a tidal volume of 400 ml for that patient, and ventilator will deliver 400 ml only at a rate of 60 liters per minute. It's not like the ventilator is going to deliver 6 liters per minute. It will deliver 400 ml tidal volume as you have said, but at the rate of 60 liters per minute, at a much higher rate. So if your patient's minute ventilation is 10 liter and you are giving FiO2 of 50%, his oxygen requirement will be 5 liter, unless your ventilator is driven by oxygen. Most of the ventilator now has an extra compressor or as a turbine or as an air source. So when the patient is working on a ventilator when it has the air or compressor, it will just consume the oxygen as per your FiO2 and minute ventilation. My unit ventilation is 10 liter. I am giving FiO2 of 50%. The oxygen consumption will be 5 liter. Doesn't matter if you set the flow rate at 80 or flow rate at 90. It is irrelevant because 80 liter is not delivered. It is the rate at which the tidal volume is delivered. So tidal volume is 400. Ventilator will deliver only 400 ml. It's not going to deliver 60 liter. Am I clear?
Okay, I think it is clear. So from an anesthesia standpoint, suppose the tidal volume is 500 milliliters and the patient is breathing, taking say 10 breaths per minute. So its respiratory cycle is 6 seconds. So if we take the inspiratory time as 2 seconds, so within these 2 seconds, the patient will take in those 500 milliliters. For the rest of the respiratory cycle, the patient is not going to breathe in. And even in these 2 seconds, the inflow is not going to be the same. The initial first 1 second, it's most of this 500 ml. So a high flow rate is necessary, not that whole amount will be delivered. Any anxiolytic to be prescribed patients in the ward?
Not routinely, but these patients, a significant number of patients are getting psychotic because of high dose of steroid, because of closed space, no human touch. They don't know whether this patient who is coming is a doctor, nurse, whoever it is. So a lot of my patients are getting psychotic. So yes, if there are patients who are requiring, along with counseling, along with maybe spending 2 minutes, 3 minutes with them discussing about their problems, we are involving the psycho-oncology team. We are starting some drugs. The patient is symptomatic, but not as a routine, not as a routine medicine.
Okay. So how do you wean somebody from invasive ventilation?
Same protocol.
Criteria. Same as others.
Same as, yeah.
Nothing specific.
No extra.
Okay. When do we repeat CT scan for COVID pneumonia? Clinically worsening patient.
Be a better person because she will follow up these patients rather than me.
Usually, if this patient is oxygen requirement is still very high, and around 14 days we have a repeat HRCT.
Pardon, once more, in
Say
patients?
suppose this patient is having a still oxygen requirement of 15 meters or so on the 14th or 15th day, right? So
Mhm.
then we repeat a HRCT to see whether this lung is healing by fibrosis or what is happening.
Right. So if we can generalize, so if a patient who is not improving on expected lines, so that would be one indication, and probably somebody who is deteriorating. So to see if you can have positions where you can ventilate and open up the lungs better. Right. There is another question on oxygen consumption. Let me make something very clear on ICU ventilators. The total oxygen consumption you cannot measure unless you have, something proximal to the connected to the main pipeline. So for all practical purposes, it's not possible to calculate how much oxygen it will consume. So for something that runs at a steady high flow rate, constant high flow rate, for them it's possible to measure. But for ventilators where the flow is episodic, it's not possible to measure. Devashish has pointed out.
That's basically the exact
I think-
formula. If we
Yeah.
apply this formula, probably know the exact how much liter you are required. Which
Yeah,
is
so you
important when
are not
taking patients from one hospital to another. Otherwise, in routine practice, we usually do not calculate.
no, unless you have the minute ventilation, exact minute ventilation, then you cannot
Yes, you cannot
measure.
No.
You have to have the exact minute. So if there is any leak, we are not measuring that. In most of the cases, we are not measuring minute ventilation very accurately. We do have some sort of measure, but not very accurately. And of course, the leak. I don't think we have any way of measuring the leak because we have a set tidal volume. We are not measuring the delivered tidal volume. We are measuring the tidal volume that is returned. So there is a
It will be an approximation. It is never going to be an accurate one.
never going to be an accurate one, right? I think why these questions are being asked repeatedly is that people want to have an idea about how much my oxygen storage is going to last because we're going to run out of it. So I think that is a worry that is playing on everyone's mind. Smaller hospitals with limited oxygen, how to deliver effectively. I think we have discussed that, how to keep it a minimum flow rate, minimum and target, and just reach the minimum target rate and how to prevent wastage. So all these factors should be taken to that. And without ventilators, I think sort of the consensus of all the three experts that we have is that the outcome of anybody who's going on a ventilator is rather poor. So most of the patients are being maintained on different modes of non-invasive ventilation and high flow oxygen. And that has shown improved survival compared to invasive ventilation. Does sublingual pyroxicum have any role in COVID management?
No.
Not in my knowledge.
No.
Don't know.
Right. So mild, I think it can act as an antipyretic. I'm not very sure. Other than that,
They're mainly analgesic. So
any specific role. It's a COX inhibitor, so will have a little bit of anti-inflammatory effect.
yes.
May have a little bit of antipyretic effect. So whether this has got enough anti-inflammatory effect to offset the effects of heightened immune response or the late onset pulmonary fibrosis, I'm not very aware. So if they are not aware, then literature has not come. So I think this discussion has proceeded quite well. We are at 10 o'clock, so
it was the
time
1
to
hour
call it a night.
discussion.
Yeah, we had a huge number of questions, and the faculty has been very generous with their time.
Yeah.
And I thank them again. And we had an excellent, not only the presentation, but the question and answer part, the participation from the audience. I think most of the time we end up by thanking the speakers first. This is one discussion where I must thank the audience. Their participation has been very, very active, very, very active. So thank you, everybody. There is a question about recording. So
Yeah.
are we going to have a recording, Krishnadi?
Yeah, we have recording also. I have recording also.
Great.
And
So that
now
was also one of the
thanking
questions.
part, can I take, Prash?
Yeah,
Because
sure.
I want to
please.
thank you also. So thank you, Sushmita Parmita,
Thank you.
Sudipta, and Palash also, because taken so much, you have moderated so well. All the faculties are excellent, and I congratulate everyone. And audience are great because today we have crossed 100, and so that I made it live on the Facebook, and Facebook also people are there to watching till now, till end they are watching. So they are there, they are present. So it was excellent, I think, and it was need of this hour because we are still on the peak of the COVID, and I think everyone will be benefited because people have so many questions. So it was fantastic program, fantastic webinar. Thank you all the audience. Thank you very much. And,
Thank you.
and I think we can come again with some other topic in COVID so that we can help people, so that people can we can have question answer sessions like that for GPs and all. Thank you so much.
Thank you,
Thank
Palash.
you.
Thank you.
Good night.
Thank you,
Appreciate
Good
it.
Vishal.
night. Good night. Thank you.
Right, everybody.
So I'm ending the meeting.